So in the first step we have learned how to make a pre-assembled frame pre-operatively. Now we will be going to discuss how to apply this pre-assembled frame on the tibia. So as we go step by step, the first step is to put a proximal tibia reference wire proximally in the tibia. The first step we learned how to make a pre-assembled tibia frame pre-operatively. Now we'll be going to discuss how to apply this pre-assembled frame on a tibia bone. So as we go step by step, the first step is to put a proximal tibial reference wire proximally in the tibia. This reference wire is called reference wire because it will decide the varus and the valgus. If you didn't put it parallel to the knee joint, let's say you put it in the varus, that it may cause a varus deformity, or if you put it like this, it may cause a valgus deformity. So the most important part is this wire must be parallel to the joint line. For this you need a C-arm for this step. The position of this wire is at the level of the head of the fibula, roughly in between the anterior and the posterior cortex. So we put the wire at the level of the head of the fibula in between the anterior and the posterior cortex, and we drill it parallel to the knee joint. So as we check on the C-arm whether it is going parallel to the joint line or not, and we take out the wire. So the wire should be parallel to the ground. So this is the first wire which we have put, and this wire should be perpendicular to the bony axis and parallel to the ground and parallel to the joint line. So distance of the wire from the joint line, as I said, it's roughly at the head of the fibula, and if the fracture is, let's say, below in the lower 1/3, you can put the wire a little below also to have an adequate knee flexion. And if the fracture is more proximally in the tibia, you may have to apply the wire more proximally in the joint line to have an adequate fixation. So commonly the wires are two diameters, 1.5 millimeter and 1.8 millimeter. 1.5 millimeter used mainly in children's, and in adults we usually use the 1.8 mm wires. And similarly the pins are of different diameters. It's 4 mm, 5 mm and 6 mm. Usually we use a tapered pin 6 millimeter and tapering to 5 millimeter. So the first wire is put parallel to the joint line, parallel to the ground, perpendicular to the bony axis, at the level of the head of the fibula, roughly in between the anterior and the posterior cortex of the tibia on the lateral side. And now we will put the pre-assembled frame, we will fix it with this proximal tibia reference wire. Now the things which we have to see while putting the frame, roughly we put a 2-finger breadth over the shin of the tibia to put the frame. We keep a distance of roughly 2-finger breadth anteriorly, and all other space is left on the posterior side because of the calf muscles. The center bolt should be on the shin of the tibia, and then we fix the wire and the ring in flush with each other. So now we have fixed the wire and the ring with a wire fixation bolt and a nut. While fixing it with the wire fixation bolt, you must understand the position of the wire fixation bolt depends on the position of the wire where it is coming in the ring. If it is coming on the upper half of the ring, the slot of the wire fixation bolt will be on the upper side, and if the wire position is in the lower half of the hole, then this slot will be on the lower side. So this is very important to avoid tensioning of the wire. So the first wire we have put, and we have fixed the pre-assembled tibial frame over it. We have seen it's roughly 2 finger breadths anteriorly. To check the rotation, this is the center bolt. It should be on the shin of the tibia. Now the next step is to fix the frame distally. For that, you should remember that you have to restore the length of the frame. In fractures, usually since the fragments are angulated, so you have to apply a traction below to restore the length, and then accordingly at the level 2 to 5 centimeters above the ankle joint line, you keep your distal ring, and over it you will be putting the distal tibia reference wire. So for that same again, you keep roughly 2 finger breadths above the shin of the tibia to make the frame parallel to the tibia. This is very important. Suppose you put the frame in this position, it will cause a deformity, a recurvatum, and if you put the frame in this position, it may cause a procurvatum deformity in the sagittal plane. So keeping the frame parallel to the tibia is very important to avoid any procurvatum or recurvatum deformity. So for that, we keep roughly 2 finger breadths and see that the frame is looking parallel to the tibia, and then I will be applying a distal tibia reference wire. Distal tibia, this is also called reference because it helps in avoiding procurvatum and recurvatum, and also you can't rely on the frame to apply the wire. Because of the angulation, the frame may get a little manipulated. So this wire also has to be applied parallel to the ankle joint, parallel to the ground, 2 to 5 centimeter above the ankle joint line. So the frame has to be kept like this, and we apply a distal tibia reference wire, and so the wire has been applied. So now we have fixed the frame with the distal tibial reference wire, and we see that the frame is parallel to the tibia and the center bolt is over the shin of the tibia. By it we see there is no rotational misalignment of the frame, and by paralleling of the tibia there is no deformity in the sagittal plane. Now we must understand, as we pass the wire, sometimes the wire may not go parallel in flush with the ring. It may go a little bent with a small distance from the ring. That's the main point, that you should never try to bend the wire and fix it with the ring. You can apply a washer, or if the distance is a little more, you can apply a male post, but never try to bend the wire. Sometimes it happens that as we put the wire instead of passing flush with the ring, it goes and hit the ring. Then you have to deviate the wire a little with the spanner, and if it's coming from this side, you can hit it on this side, or if the wire is more towards the other side, there is no problem. You can put the wire and you can hit it like this, and it may come on the other side. It's totally fine if the wire is coming from the one side and going out from the other side. That's not a problem. So this is your basic frame assembly which is done. You have a frame which is fixed proximally and distally with the reference wires. So this 80% of your job is done. And now what you just need is to add on the wires and the pins to make the frame more strong. But your basic frame assembly is done and your 80% work is completed. So now the next step is we'll be adding on the wires As I told earlier, the wires are of three types. First is the reference wires, proximal tibia and the distal tibia, which decides the frame orientation. Once it is done, then we apply the reduction wires, because you must understand, in the workshop this is a normal bone, but in your operation theatres you will be getting the cases of the fractures. So you may have to reduce the fracture. So to reduce the fracture, we now apply the second type of wires, which we call as reduction wires. So for that you can use an olive wire to reduce the fragment. If it's a coronal plane deformity, if there is a displacement on the medial or the lateral side, then you have to. Now suppose there is a fracture and the distal fragment is reduced on this side, on the lateral side, and we want to reduce the fracture from lateral to the medial side. So for that we use an olive wire. This is an olive wire with a stopper here. So we will be applying the olive wire in a fashion similar to the other wires, and this wire, the stopper will stop on the lateral surface of the bone. Now as I am passing the wire, my wire is trucking the ring. So I am passing the wire from this side, so I will just push the wire with the spanner on the inner side, and I will pass the wire on the inner side. So this is totally fine. So as we put the wire, then we have to tension the wire. So for that we have a tensionometer with which we gives the tension to the wire. So suppose I want to give the tension from this side. So first I will tighten the wire fixation bolt on the other side. And I will tighten it fully so that the wire doesn't slip. You may also bend the wire a little to check whether it is tightened or not. Then I apply a tensionometer on the other side and I tension the wire. Now I put the tensionometer over the wire and I loosen the nut a little and I tension the wire. There are markings on this tensionometer. The maximum markings are 130, and we usually do up to, on an average, 110. We may go up to 130. So as we do the tensioning, then we again tighten the nut so that the wire gets properly tightened and tensioned. And then we release the tensionometer by moving on the reverse direction, and then we remove the tensionometer. So this is the way by which we get tension to the wire, and if this side is properly tightened, the bent side will not slip in through the wire fixation bolt. So as we put the wire, we use roughly 3 finger breadths distance to keep this much amount of wire, and we cut the wire. And then to bend the wire, we gradually turn it into round to make it a smooth curve, and try to get the tip inside the hole on the ring to avoid the tip causing injury during the dressing. So we make it in a smooth bend and try to keep the tip of the wire inside the hole on the ring so that it avoid any injury during the dressing. We keep it round so that if later on we may need to reapply the tension, we can again make it straight to give the tension. So in this way, we bend all the wires as we put it inside the bone. Now this is a case of a fractured tibia with a displacement. There is displacement of the distal fragment on the lateral side in the coronal plane, and in the sagittal plane there is a posterior sagging of the proximal fragment. So you have two types of displacements. In the coronal plane there is a lateral displacement of the distal tibia, and in the sagittal plane there is a posterior displacement of the proximal tibia. So to correct this displacement, we put the wires which we call as reduction wires. So for the coronal plane deformity, the mediolateral coronal plane displacement, the mediolateral displacement, we take the use of these olive wires with a stopper. So since the displacement is on the lateral side, we put the olive wire from the lateral side. So that the stopper, it touches the bone, and then we remove the drill. Now to correct the lateral displacement, we have applied an olive wire and fixed it loosely with the wire fixation bolt and the nut on the both sides. Now to procedure to correct this displacement with the olive wire, first we will tensioning on this side on which we want to correct the displacement. So we will putting a tensionometer on this side, we will tension on this side. When the bone will reduce, we will tighten this wire fixation bolt and the nut. After that we will again tighten this wire fixation bolt and the nut, and then we will remove the tensionometer. The first step is we apply a tensionometer on the side on which there is a displacement, and then we start giving the tension. To apply the tensionometer, this is a manual tensionometer. We applied the tensionometer and then we tighten it bolt, and see, as we tighten it, you will be seeing the displacement gets corrected. And now we will fix, as we are satisfied with the correction of the displacement. Now we will tighten the wire fixation bolt and the nut on this side, and then we will tighten the wire fixation bolt and the nut on the side of the tensionometer, so that the bone doesn't get displaced again. The wire is properly tensioned and maintaining the displacement. Now as this is tension, now we remove the tension. We loosen the tensionometer and then we remove the tensionometer. Now you see the mediolateral displacement is reduced, but on the sagittal plane there is still a displacement of the proximal fragment on the posterior side. So to correct the displacement on the sagittal side, there is another trick. In this, we put a reduction wire on the proximal fragment and we fix the wire to one hole above where it usually comes. So as we will again tighten the wire, it will pull the fragment on the anterior side. So we will put a reduction wire on the proximal fragment and then see the wire is coming on this hole. Now we fix the wire one hole above. on both the sides, here also and here also. So we fix the wire one hole above from the hole where it usually comes, and then we apply tension on both the wires. So we have applied the wire one hole above, and as now we will tension it, it will pull the proximal fragment anteriorly and it will reduce the fracture. So to correct the displacement, we first tighten on the other side the wire fixation bolt and the nut, and we apply tensionometer on this side. We have kept the bolt and the nut loosened, we haven't tightened it, and then we apply a tensionometer. We first apply the tensionometer with the slopey side towards the nut, the smaller one, and then as we do the tension, the fragment gets reduced. As the fragment gets reduced, so as we apply the tension, the fragment gets reduced, and now there is no displacement on the sagittal frame. When it's thoroughly reduced, we tighten the wire fixation bolt and the nut, and then we take out the tensionometer. So we have tightened the wire fixation bolt and the nut, and now we have loosened the tensionometer and we have removed it. So now your fracture is properly reduced. So you must understand that in an Agrawal frame assembly, first we applied the reference wires, the proximal tibia and the distal tibia, and fixed the pre-assembled frame over it. Then to reduce the fracture, we applied reduction wires. For a mediolateral coronal plane displacement, we used an olive wire as a reduction wire. And for a sagittal anteroposterior displacement, we fixed the reduction wire one hole above on both the sides, and as we tensioned it, we got a perfect reduction. So now in this frame, there are reference wires and there are reduction wires, and there is a frame, and now the last step is to just apply more wires and the pins, which we call as stabilization wires, to increase the strength of the frame. But at this stage, your 90% work is done, and you have to just apply the wires and the pins in the configurations of your choice just to increase the strength of the frame. Otherwise, most of your surgery is done at this stage. To add the stabilization wire in the distal tibia, we have already applied one reference wire. So we apply a second stabilization wire on the other side of the ring, let's say from anterolateral to posterior direction. So as we reach the second cortex, it's better to wait for 5 to 10 seconds to avoid the thermal necrosis. And this is a spirit swab which helps in keeping the wire cold. And you keep holding the wire with the spirit swab. It helps you in maintaining the alignment and the direction. And you apply the second wire. Now let's say your stabilization wire doesn't go flush with the ring. So don't try to bend the wire on the ring. If it's a small distance, use a washer, or if it's a distance is bigger, you can use a male post. When the wire is not flush with the ring, you can apply a washer and fix the wire. So these are the 2 mm washers. These comes with a slot and also without a slot. It depends on you. In this we have applied 3 2 mm washers and fixed the wire in the wire fixation bolt. So in the distal tibia, either you can apply 3 wires or 1 wire and 2 pins, or 2 wires and 1 pin. It depends on the surgeon mainly which configuration they want to choose. In this video we are using 3 wires. So first 2 wires we have put in flush with the ring. The third wire, we put the wire at a little distance, usually 2 male posts, 2 holes of a male post at a distance from the ring. So this wire is called a drop wire. It increases the mechanical stability of the frame many folds, because when the wires are flush with the ring, you can still move the frame up and down and on the mediolateral side. But as you put a drop wire away from the ring and you fix the drop wire with the ring, your frame gets really stable and you will not be able to move the frame in any direction. So this is a drop wire. We have put a little away from the ring and we have fixed the drop wire with a 2 hole male post and a wire fixation bolt and a nut. This increases the stability of the frame multiple times. So in the distal tibia we have applied a 3 wire configuration, 2 wires at an angle in flush with the ring and 1 drop wire a little away from the ring. So 3 wires in 1 ring is sufficient. In place of 3 wires, you can have 1 wire and 2 pins, or 2 wire and 1 pin. It depends on the surgeon's choice and the patient. That's it. In the proximal tibia, we have applied 1 reference wire. Now we are going to add the second wire, the stabilization wire, at an angle to the frame of the tibia, to the first wire. Now this second wire is the stabilization wire, which is applied in flush with the ring, and a third wire we can apply as a drop wire away from the ring. Similarly, you can have 1 wire and 2 pin configuration, or 3 wire configuration, or 2 wires and 1 pin configuration. So in the tibia we are adding a second wire, the stabilization wire. We apply it at an angle to the first tibia reference wire. And we try to apply it in flush with the ring, and if there is some distance, then you can apply a washer or a male post, low profile. So in the proximal tibia we have applied 1 reference wire, 1 stabilization wire, and now we are going to apply a third wire, the drop wire, a little away from the ring, usually 2 holes away of a male post. So we have applied a drop wire, and now we'll be going to fix it with 2 hole male post on both the sides. So in the middle rings we have put 1 reduction wire on both the rings. Now we can have 1 more wire as the stabilization wire to increase the strength of the frame. So you can apply one wire or one pin or two wires. Usually 2-point fixation is enough on the middle ring with two wires or one wire and one pin. But if the bone is very osteoporosed, there are chances of loosening. You may go for 3 wires or one wire and two pins. So we have applied one wire already, and now we are going to apply the second wire on the other side of the ring in flush with the ring. So we are applying the second wire in flush with the ring. Now in the third ring we had applied one reduction wire, and we are going to apply a second wire, the stabilization wire, to increase the frame stability. We put the wire on the other side of the ring and try to keep as maximum angle as possible from the first wire. So as we pierce the wire and we reach the second cortex, try to wait for 5 to 10 seconds and then again drill the wire. Now your basic Elizarov frame gets completed. You have a frame with 4 rings. For the level of the ring on the frame, if there is a mid-shaft fracture, tibia, we usually take one hand breadth and put 2 rings on either side of the fracture. It's better to put the rings closer to the fracture, usually at a distance of 1 hand breadth. The proximal ring is at the level of the head of the fibula. The distal ring is 2 to 5 centimeters above the ankle joint line. So these are the level of the rings. Initially we fixed the rings with 2 threaded rods between the 2 rings, and now once we have finished the frame, we will be adding more threaded rods, usually 3 to 4 rods. It's many surgeons used to apply 4 rods to have maximum stability, but 3 rods are also sufficient. If the ring is not full, then you have to apply 4 rods. If it's a full ring, then 3 rods also fine, and you can apply 4 rods also. So in this frame we will be applying 4 rods between each rings, and then after putting the rods, one of the last step is, if there is a gap at the fracture side after reduction, you can compress the rods over the fracture side to eliminate the gap. And the last step, after whole frame is finished, you make sure that you check that all your nuts and the bolts are tightened. So as the frame is finished, you start from the central bolt and the nut which connects the rings, and you check whether it's fully tightened or not on all the rings, both the sides. So if it's 4 ring, then you will be having 8 central bolts and the nuts. Then you check the rods on both the sides, whether the nuts are properly tightened or not. So if you have 4 rods here, 4 here and 4 here, you have 12 rods and 2 sides, so you have 24 rods and the nuts to check. After you have checked the rods, then you check the wire fixation bolts on all the wires, whether they are properly tightened or not. So first you check the central bolts, then you check the nuts over the rods, and then you check the wire fixation bolts, and then your frame is complete and surgery is done. Thank you. So in this complete frame, in the proximal tibia, we use 3 wires, 2 wire flush with the ring and 1 drop wire away from the ring. Distally we also use 3 wires, 2 wires flush with the ring and 1 drop wire away from the ring. In the middle 2 rings we use 2 wires flush with the rings. This and this is a reference wire, proximal tibia reference wire and the distal tibia reference wire. These are the first wires we applied. Then we applied the reduction wire on both the middle rings to reduce the fracture, and then we applied the stabilization wires to increase the stability of the frame. Thank you.